Good evening. Um, so today I am discussing the fourth part of my topic on acute kidney injury and CRRT, where I will discuss mainly the principles of CRRT. So we have to understand what are the principles behind the machine which is being used for dialysis or continuous renal replacement therapy CRRT inside the ICU. So to understand the mechanism through which those machine works, we have to understand four main principles, and those are diffusion, ultrafiltration, convection and solute drag, and adsorption. Coming to the diffusion, and we must have read throughout our medical training what is diffusion. It's a movement of solute through semi-permeable membrane from an area of higher concentration to area of lower concentration until equilibrium has been established. And when we say semi-permeable membrane, it's a membrane which allows some of the particle depending on the size and electrical charge, while it stops the other, probably bigger molecule or differently charged molecules. So by this mechanism, most of our hemodialysis machine works. Most of the hemodialysis machines in the renal unit works on this mode. And when we use continuous hemodialysis mode like CVVHD mode, which is called continuous veno-venous hemodialysis mode, then we use this mechanism. And when we say we use mechanism, that means this hemodialysis machine work on diffusion process. And what we do, we try to do that we pull the patient's blood from here, goes into the a compartment, and then this from this compartment it goes back. But you can see there is a membrane here, and after that membrane there is another fluid flowing, and we try to keep it in the opposite direction so that we can get a benefit of counter current mechanism. So we have to understand that that this fluid, which is depicted here in the green color, is called dialysate in medical term, and it don't contains it don't contains the molecule which we want to remove from the blood. So, or it contains the electrolytes in the range which will allow the diffusion of excess of those electrolytes. So it will try to equilibrate to normal hemostasis. So dialysate will flow in the green chamber, blood will flow in the red chamber, and you will find there will be transfer of the excess molecule from one chamber to another chamber, and we'll get a benefit of counter current mechanism along with the diffusion. in case of hemodialysis. So whenever somebody says hemodialysis, we are using diffusion mm, as a mechanism. Next mechanism which is under discussion is ultrafiltration. So try to remember, ultrafiltration is nothing more than squeezing blood again through a semi-permeable membrane, and it is responsible mainly for removal of fluid, removal of water, with probably some of the electrolytes. Uh, it works by the mechanism of pressure. So either we apply a positive pressure on one compartment as being applied here on this side. That is that the fluid is going to other compartment because of the pressure. And similarly, if you apply a negative pressure somewhere as being applied on this second foot picture, it will suck, it will, you can say, it will suck out the fluid from other chamber. So there will be flow of fluid from one chamber to another chamber because of pressure, either it's positive pressure or negative pressure. Then it will be called as ultrafiltration, and this mechanism is mainly being used for removal of the fluid, uh, and most of the machine use it with the dialysis and even with the hemofiltration, which we'll discuss later. uh, and one of the mode which we use in the continuous CRRT is called as a scuff, only uses the ultrafiltration mechanism. So if somebody asks which mode uses ultrafiltration as a mechanism in isolation, that is called as a scuff, slow continuous ultrafiltration. Going to the next slide. Next mechanism is convection. So, so convection is the one way movement of solute through semi permeable membrane with a water flow, which is also called as solvent drag. So when we push one one of the fluid through semi permeable membrane, the fluid goes from one chamber to another chamber, but along with the solvent fluid or solvent, solute also get dragged with the solvent. That is called as solvent drag, and that is the mechanism which is being used in hemofiltration mode of our CRRT machine. So what we are doing in the machine by this method is that we are giving some extra fluid mixing it inside the blood with the blood, and then pushing diluted blood to the blood chamber with the pump. And because uh, of blood and the mixed fluid and pressure, the the fluid with will pass, water will pass from one chamber to another chamber. Along with that water, solute will also move because of solvent drag, and this will go to the waste. The fluid which is being mixed in the blood can be mixed in before filter or after filter, and that's why we call it as pre-filter replacement fluid or post-filter replacement fluid. And 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 they, that they work differently, but ultimate mechanism is that we dilute blood, we push it to the pump, and because of that fluid moves, and along with that some plasma moves from blood compartment to other compartment of the filter, which is being going to the waste. So that is the mechanism through which hemofiltration works. Another combination of mode which is called as hemodiafiltration. So this is nothing but combination of two mechanisms which we have discussed. One is hemodialysis and another one is hemofiltration, which if we combine it together, it's called as hemodiafiltration. So here we are putting some replacement fluid here before or after filter, depending whether we are using pre-filter or post-filter. We'll discuss what later what is the pre-filter and what is the post-filter things. But to here we'll put some replacement fluid, and we will also make a flow of he dialysate in counter current route. So here both mechanism will work. There will be diffusion of solutes from blood compartment to dialysate compartment, but there will be expulsion of the replacement fluid which will drag solute with the solvent. So both mechanism will work together, lead to a mode which is called as hemodiafiltration mode. Some of the selective filters use mechanism which is called adsorption, and it is so it is a phenomena in which molecules get attached on the surface of membrane, and many of the time it is being used for the treatment of the fat soluble drugs, and we use charcoal filter, sometimes cytokine filter, uh, endotoxin filters. So these are the filters which are being attached to the CRRT machine, which work on adsorption by mechanism of adsorption. So the molecules which are targeted to be removed from the body binds on the membrane, and then after like using for particular duration, you can just throw the filter, so the toxins will be removed from the body. So these are the mechanisms which are being used in our CRRT machine. One is diffusion, which is being used for hemodialysis. Another is convection, which is being used for um, hemofiltration. Combination is being used for hemodiafiltration. Ultrafiltration is being used as an isolated mode in scuff, and it is also being used in cases of hemodialysis, hemofiltration, and hemodiafiltration to remove excessive of fluid from the body. And the last one is adsorption, which we are using for removal of specific toxins which get attached to the membrane and it get removed from the body. Efficacy of uh, diffusive clearance and convective clearance is different, and we find that hemofiltration is more efficient in removal of solute, but it don't differentiate between the size of molecule. And as you can see, there is a graph, this in this graph, which is clearly showing that the diffusion a lot depend on the molecular size, and as the molecular size increases, the excretion decreases, while in cases of convection it's almost constant, and suddenly excretion of molecule stops at particular size of the molecule. So in case of convection, you will find the even larger molecules will be removed quite efficiently, and it is almost a level of 10,000 Dalton. You will find that uh, that will be a cutoff level where after which above which there will be no filtration in case of convective clearance. So definitely convective clearance is more efficient, and you will find it in the cases of lactate removal that hemofiltration is more effective in removal of lactate or this type of molecule from the body. So this diagram just shows the cutoff point uh, where according to the molecular size. So most of the time you will find that we need to have we need mostly to remove the low molecular weight um, mm, metabolites like creatinine, urea, potassium. We don't want we don't focus too much in to remove uh, bigger molecules, but in cases of toxicology it becomes more important that we use hemofiltration, because in hemofiltration we can more efficiently remove uh, bigger molecules. This is the now coming to the different modes um, of CRRT machine, and I will start with scuff because this is quite easy one, where you will find that um, just you need to pump the blood through the filter with a pressure, and this will squeeze the blood and lead to removal of the fluid or solvent, or you can say plasma from the body. So it's not plasma, actually it's mostly water with a small amount of electrolytes. So here this is the blood source from the patient, it's coming down, and then there is a blood pump here which will force the blood through the filter, and then this will go back to the patient. There are different safety mechanisms attached, uh, like air detector inside the circuit, so it will detect bubble and stop the flow to avoid air embolism. Uh, and there are syringe pump attachment and all to deliver if you want to give some anticoagulant. But you can see it is shown in yellow where the effluent fluid or ultrafiltrate is getting collected. Coming to the CVVH, and when we say CVVH, it's called as continuous veno-venous hemofiltration. So we don't say CVVHF, we say CVVH. It's continuous veno-venous hemofiltration. And as I told that hemofiltration work on the mechanism where we mixed some replacement fluid inside the blood, and it dilutes blood, and that solvent or the replacement fluid, when it goes to the filter, it, it comes out in the effluent fluid, and along with that it drags the solutes. So here also this is the source from where the patient blood is coming from the patient. It's being pumped to the filter. So there is a part of ultrafiltration. The pump is there, blood is being forced there. It's maintaining flow, along with that it's pressurizing blood inside the filter. So you put some fluid before the filter, and here you just assume that we are going to give pre-filter fluid. So this fluid goes to the filter, and then the mechanism of solvent drag works and remove the solute. Another pink diagram here is actually post filter replacement. So there means you can dilute or you can put the solvent either pre-filter or post-filter, which will go to the patient and come back. So the dilution will be less in case of post-filter, because it will dilute whole blood inside the body. So the filter will get still concentrated blood. So you have to remember, if it will get concentrated blood, there will be more risk of clotting. But because blood is concentrated, there are lots of solute, so there will be more effective solvent drag in case of post filter replacement fluid. But if you use it pre-filter, it will dilute the blood a lot, because the amount of blood which is coming out of the body, will just that amount of blood will be diluted, so that the filter will get a lot diluted blood, so the risk of clotting will be less. But because there is less number of solutes to be removed, the effectivity or effectiveness of the filtration will be less. So what we do is that we divide the pre-filter and post-filter, and we try to give some, mostly 2 is to 3 or half and half, either as a pre-filter and post-filter, and we keep watching uh, which is most means which patient will suit between what level. So we try to give as much as post filter, because post filter is make it more effective, but again with the risk of clotting. With the use of citrate, it has definitely improved, because citrate doesn't cause clotting inside the body, because it get neutralized before reaching to the body by calcium. So we usually divide as a post filter 2/3 and pre filter 1/3, and then we go from there, and then we keep watching on the risk of clotting by monitoring transmembrane pressure. This diagram is for CVVHD. It's called as continuous veno-venous hemodialysis. This is the same diagram which will be for intermittent hemodialysis. Here you can find same source of blood from the patient, pump which is maintaining flow, pushing the blood inside the filter. But in the counter current method, dialysate is coming from here and flowing from here to this effluent bottle, and there is exchange of electrolyte by diffusion is happening inside the filtration, and then ultimately blood will flow to the patient from here to here with same all safety mechanism of air detector, pressure detector. So we have to means here it's just diffusion is working, but along with that pump is there. So you have to decide in the prescription how much fluid you have to remove and put there, and that much amount of ultrafiltrate will be removed with the ultrafiltration mechanism. For CVVHDF, it's a combination of hemodialysis and hemofiltration. You will find here pre and post filter replacement fluid. You will find a dialysate going on, a pump which will force the blood. So everything is there on CVVHDF, that is continuous veno-venous hemodiafiltration. Uh, uh, so it is the most efficient mode of CRRT. Um, the I have tried to be as simple as possible to explain the mechanism of uh, different mode of CRRT. Thank you for the patience for listening this talk. I would be thankful if you can like and subscribe my channel. I will be coming soon with my next presentation on this topic with prescription and troubleshooting of CRRT machine. Thank you very much.